Hello friends. So today we'll be discussing on anti-anginal drugs. So we'll be covering this under two sessions. The first part we'll see the pathophysiology of angina and we'll concentrate on nitrates, which is the most important drug class that you should learn in angina. And in the second part we'll cover the remaining classes of anti-anginal drugs. So basically what is meant by anti-anginal drugs? These are drugs that are used to terminate or abort an acute attack of angina. Now the question comes, what is meant by angina? Okay, so where there is a transient episodes of myocardial ischemia. So how does this myocardial ischemia or there is deficiency of oxygen to the myocardium happens? When there is an imbalance between the oxygen supply and the oxygen demand. Either the oxygen demand increases, like in case of when you're exercising or when you're in emotional stress, your oxygen demand increases, or the oxygen supply decreases. That is because of an atherosclerotic plaque, the flow through the blood vessels decreases, and as a result, the oxygen supply decreases. So when there is an imbalance between this, that will result in ischemia. If it is a transient ischemia, that ischemic pain is manifested as the anginal pain. But usually when the patient takes rest, the flow is restored and the pain disappears. So that is what is known as angina. So we classically say there are three types of angina. The most common one is a classical angina, otherwise known as stable angina. So what happens in classical angina or stable angina? There is a atherosclerotic plaque in the large conducting vessels. So this is atherosclerotic plaque. So normally at rest, there is no problem in the flow of blood through these occluded vessel, partially occluded vessel. But when there is an increased demand, the flow through those occluded vessels is not enough to supply for this increased demand, and as a result, the patient gets pain, anginal pain. So this is precipitated by exercise, exertion or emotion, etc. There is atherosclerotic occlusion of large coronary arteries. Why I'm saying this little bit in detail is so that you get an idea about which drugs we can use for which type of angina. From pharmacology point of view, this won't be asked as a question, but you need to have an idea about what is meant by these types of angina. Now, what is meant by unstable angina? Where there is a rupture of this atherosclerotic plaque. So, there is a rupture and this is not predictable. This can occur even at rest, and there is further platelet adhesion, and that can even go in for acute myocardial infarction. So, unstable angina is actually included under acute coronary syndrome. Acute coronary syndrome includes unstable angina, ST elevation MI and non-ST elevation MI. All these three are included under acute coronary syndrome. So this is due to rupture of atherosclerotic plaque and platelet deposition and occlusion happens. Here, antiplatelets play a major important role. And a rare form is known as variant angina, otherwise known as Prince-Mettels angina, where this is also unpredictable. There is a vasospasm of a particular area of the coronary arteries, localized coronary vasospasm. So these are the three types of angina. The most common one is a classical angina, otherwise known as stable angina. So now we come to the classification of anti-anginal drugs. So basically what does this anti-anginal drugs do? They either try to increase the oxygen supply, that is by causing coronary vasodilatation, or they try to decrease the oxygen demand. How can you decrease the oxygen demand? When does this oxygen demand increases? When the cardiac workload increases. So they try to decrease the cardiac workload. How can you reduce the cardiac workload? By reducing the heart rate, or by causing venodilatation, or by decreasing the preload, or by decreasing the afterload. So these are different mechanisms by which these anti-anginal drugs act. So most important drug is nitrates. Then you have beta blockers, calcium channel blockers, potassium channel blockers, and few newer drugs. So we'll cover in detail about nitrates. The rest of the groups we have discussed in depth in other chapters, but we'll cover their anti-anginal actions in this class. So this is what I told. Basically, we need to balance the oxygen demand and the oxygen supply. So oxygen demand is based on the workload that in turn is dependent on heart rate, contractility, preload and afterload. So you can see beta blockers and calcium channel blockers decreases the heart rate and decreases the force of contraction, thereby decreasing the workload. Preload and afterload is decreased mainly by nitrates as well as by calcium channel blockers. Supply increased is by increasing the coronary blood flow, that is mainly by vasodilators, plus improving the regional myocardial blood flow by other agents like antithrombotics and statins. So now we come to nitrates. So nitrates, any drug, what are the headings under which you should write for the exam? If a drug class is being asked, what all you should write? You should write the examples. What is the mechanism of action? What are the pharmacological actions, that is actions on the other systems? What are important pharmacokinetics, adverse drug reactions and uses? Okay. At least 3 headings should be there, that is mechanism of action, adverse effects, uses, examples. At least these 4 headings should be there. To be a complete answer, all these headings should be there. So let's see one by one under each of these headings. Okay. So what are the examples, or in other words, what's the classification of nitrates? We have short acting and long acting. Short acting, we have glyceryl trinitrate or GTN, otherwise known as nitroglycerin, which we can keep sublingually as well as oral preparations are there. Long acting, you have isosorbide dinitrate, mononitrate, erythritol tetranitrate, pentaerythrol tetranitrate and all. Any 2 examples you can study. These are the commonly used one, isosorbide mononitrate and isosorbide dinitrate, and glyceryl trinitrate, otherwise known as nitroglycerin. Now we come to mechanism of action. So from the word itself, you know what will be the mechanism. Nitrates, they act by releasing the nitric oxide. Okay, at least remember that. So they get denitrated in the smooth muscle cells and releases the free radical nitric oxide. What does this nitric oxide do? They activate the enzyme guanyl cyclase. Just like adenyl cyclase. What does adenyl cyclase do? They increase the levels of cyclic AMP. Similarly, guanyl cyclase increases the levels of cyclic GMP, and this in turn causes smooth muscle relaxation. How does it cause smooth muscle relaxation? This cyclic GMP will cause dephosphorylation of myosin light chain kinase. So this myosin light chain kinase phosphorylation is required for active contraction of myosin and actin. Okay, you can see here. Here you can see guanyl cyclase, and there is increased production of cyclic GMP. What does the cyclic GMP do? It causes dephosphorylation of myosin light chain, and the phosphorylated myosin light chain is required for activation of myosin, which in turn will combine with actin and causes contraction. So by dephosphorylation, the myosin activation is getting inhibited. So myosin actin coupling is not happening. That results in smooth muscle relaxation. Okay, so basically you should remember nitrates releases nitric oxide, which in turn stimulates the guanyl cyclase, increases the cyclic GMP and causes smooth muscle relaxation. So what are the pharmacological actions? So main action is on the vascular smooth muscles, and vascular smooth muscles includes venules as well as arterioles. It is more of a venodilator than an arteriolar dilator. It dilates veins much more than the arteries. So it reduces the preload. That is, there is a venodilatation, peripheral pooling of blood is there, venous return is reduced. As a result, the preload is reduced, end diastolic pressure is reduced. So the heart is able to, the cardiac workload is reduced. In addition, it causes coronary vasodilatation, and basically it causes a redistribution of blood flow. Rather than increasing the coronary blood flow, it causes redistribution of blood flow. What is meant by this redistribution? The peculiarity of nitrates is it dilates a large conducting vessel. So the large conducting vessels will be sending out this smaller resistant vessels. Okay. So if this is dilated, what will happen? Already, if this is a ischemic area. The ischemia is a strong stimulus for vasodilation. So this will be, the vessels in this ischemic area will be dilated. Okay. Whereas in the non-ischemic area, the tone of those resistant vessels is well maintained. Okay. So what happens if this larger conducting vessel is getting dilated? The blood flow is redirected to this comparatively ischemic areas, while the blood flow to the non-ischemic area is maintained as such. The previous levels are even reduced. That will also get redistributed to the ischemic area. So there is basically a redistribution of blood flow that is happening when you're giving nitrates. But on the contrary, initially there was another drug called as dipyridamole that was developed for angina, but then it was not used nowadays for angina. We use it because of its antiplatelet action. We use it as an antithrombotic agent. Why it is not used for angina these days is because of this coronary steal phenomenon. What is it stealing? Unlike nitrates, it does not dilate these large conducting vessels. It dilates these resistant vessels. So what happens is, already in the ischemic area, it is maximally dilated because of this ischemic stimuli, but the non-ischemic vessels are also getting dilated when you're giving dipyridamole. So whatever blood flow is coming through this conductance vessels is getting redirected to the non-ischemic vessels, stealing whatever blood flow in the already ischemic area. That is known as, that worsens and actually precipitated acute death, sudden deaths. So that is known as coronary steal phenomenon, which is seen with dipyridamole, but that is not seen with nitrates. Arteriolar dilatation is seen in higher concentration. Now, other smooth muscles are also dilated, like it relaxes the muscles of the gastrointestinal tract, genitourinary tract, and bronchi. And platelets, it has got antiplatelet action, which is useful in case of unstable angina. So that is regarding the pharmacological action. So mechanism of action, we have told, by releasing nitric oxide, increase guanylyl cyclase activity, increase cyclic GMP, resulting in smooth muscle relaxation. Vascular pharmacological action, it causes vascular smooth muscle relaxation, relaxation of other smooth muscles, as well as platelet aggregation is inhibited. Pharmacokinetics, this is one drug which is available in different routes of administration, different dosage forms. Like tablets, it is available as oral, sublingual. Sublingual spray is available, transdermal patches there, ointments, parenteral preparations are all present. So you can see tablets are there, injection, sublingual spray, transdermal patch, ointment are all different dosage forms. Now we come to the adverse effects. What's the easy method to remember the adverse effects? If you don't know any adverse effects, think about the pharmacological actions. Extension of the pharmacological action, you will get the adverse effects also. What does it do? It causes smooth muscle relaxation of blood vessels. So not only coronary blood vessels, other blood vessels are also relaxed, like meningeal blood vessels, and that will result in throbbing headache. This is one of the very limiting side effect of nitrates. If you ask any patients who newly started on nitrates, the main complaint they'll be saying will be about this throbbing headache. That can be severe limitation that may even force a patient to stop taking the drug. So there can be throbbing headache, and there can be flushing, reflex tachycardia, syncope, and rarely large doses if you give, it can cause methemoglobinemia, drug rash, and a very important long-term side effect of nitrates is tolerance. What is meant by tolerance? That is, the patient is requiring a higher dose to produce the same action. Okay. So, what can you do to prevent the development of tolerance? You provide nitrate-free intervals. The tolerance is removed very easily if you provide a nitrate-free interval. So, what you do is give the nitrate tablets morning 8 a.m. and evening 4 p.m. So, minimum 12 hours time you are giving in between as a nitrate-free interval period to prevent the development of tolerance. Another problem is dependence. What is dependence? If you suddenly stop taking nitrates, the patient will precipitate an anginal episode. So, you should slowly taper and then stop. So repeated or continuous exposure result in tolerance. Provide nitrate-free interval at least 8 hours a day. And have you heard about the Monday disease? That is those people, that workers who are working with explosive factories, they are constantly in exposure to this nitrates. So what happens is they uh, develop this headache every morning, Monday morning, and by Thursday they get accustomed to it or they develop tolerance to it, and then weekends they don't get exposure to it. There is no headache, and Monday again when they come back they are getting exposed to those nitrates and they again get this headache and other problems, and this is why it is known as Monday disease. And dependence is sudden withdrawal after prolonged therapy can suddenly result in spasm of the coronary and peripheral vessels, and that can lead to sudden death. Now, what are the uses of nitrates? Now, you can surely say it is used for angina. What type of angina? All three types of angina it has got used. Okay, so we use it for stable angina, variant angina, and unstable angina. So that is okay. Angina, all types. Then we use it for acute coronary syndrome, for congestive heart failure, severe hypertension. Since it relaxes the biliary as well as esophageal smooth muscles, it is used for biliary spasm and esophageal spasm, also for cyanide poisoning. We'll see one by one how it is useful for each of these conditions. First, we come to angina. So, how does it work in angina? By reducing the preload, and at higher doses it reduces the afterload. By both this action, the cardiac workload is reduced. There is less oxygen demand. So this is why it is useful in stable angina. Now, by coronary vasodilation, it improves the oxygen supply, by which we use it for variant angina. Okay. And by platelet inhibition, it is useful for unstable angina. So it is useful in all three types of angina. Now, how does it useful in congestive heart failure? Again, by venodilatation, venous pooling, there is decreased preload, and in diastolic volume, heart workload is reduced and improves the left ventricular function and decreases the venous congestion. Now, then other uses we have told, we use it for severe hypertension. We can use it, sodium glycerol trinitrate parenteral preparation can be used. We use it for biliary esophageal spasm. Another important use is in case of cyanide poisoning. How does it act in cyanide poisoning? Usually the cyanide toxicity is because cyanide combines, have got very high affinity for cytochrome oxidase and thereby producing its toxicity. So what does this nitrates do? Nitrates, they combine with hemoglobin to form methemoglobin, and we use mild potent agents like sodium nitrates because you are using it for cyanide poisoning. We have to use a large dose. If you are using other potent nitrates, that can result in severe hypotension. Okay, so we use mild agents like sodium nitrates, and it combines with hemoglobin forming methemoglobin, and this methemoglobin has got very high affinity for cyanide. So it combines with cyanide forming cyan methemoglobin, and to increase its excretion out of the body you give another agent known as sodium thiosulfate that combines with its cyan methemoglobin and produces methemoglobin and sodium thiocyanate, which is not easily soluble and gets excreted out from the body. So why sodium nitrate? Why not other agents? Because if you are using other potent nitrates in a large dose, that can result in severe hypotension. So that is a rationale for nitrates in cyanide poisoning. Another important drug interaction you should remember for nitrates is you should not combine it with sildenafil. What is sildenafil? It's a drug that we use for erectile dysfunction. At least 2-hour gap should be there between use of nitrates and sildenafil, because sildenafil, how does it act? It acts by inhibiting phosphodiesterase enzyme and it increases the cyclic AMP levels, and that will also result in vasodilatation. So when you combine it with the nitrate, that can result in severe hypotension and patient can go in for a cardiac arrest. So that is another important drug interaction of nitrates. So now what we have discussed is we have said what is meant by angina, what are the different types of angina, and we have discussed in detail about nitrates. Nitrates is a very important question that can be asked as a short note. So remember the mechanism of action, the pharmacological actions, most importantly uses, the different uses not only in angina but also in congestive heart failure, hypertension, in cyanide poisoning, biliary esophageal spasm, and important adverse effects. Okay, so hope it is clear. Thank you for listening.